Welcome to the Mug Hub podcast, the ultimate platform for all things related to medicine's use, patient care, and the incredible world of pharmacy. We are your hosts, Connor and Sian, and we're thrilled to have you join us today.
Here at the Mug Hub podcast, we're passionate about empowering future pharmacists, expanding your knowledge and igniting your curiosity. Whether you're a first year embarking on your pharmacy journey or a final year getting ready to go out into practice, this podcast is designed just for you.
Across our series, we delve into 4 captivating themes that will take you on an enlightening and entertaining journey. From exploring intriguing clinical topics to showcasing the extraordinary individuals who make up our incredible teams, we're here to unlock the secrets of the pharmacy world.
So grab your favourite mug, settle in, and let's embark on an incredible voyage together. Get ready to be inspired, educated and motivated as we unlock the vast potential of pharmacy and the vital role it plays in healthcare.
Hello and welcome back to the Mug Hub podcast. So I was unable to get anybody else in, so I'm going to have to interview you. So please welcome our very special guest, Dr. Sian Williams.
Thank you.
Who is not only a senior lecturer in medicine's use, but also a health psychologist by background. Badonk indeed. So not a pharmacist, which I think is...
No, not a pharmacist.
It's great to have you in the team. So what is a health psychologist and what sort of activities would you get up to?
So health psychology is obviously a branch of psychology. So psychology is the study of human brain and behaviour. And a health psychologist is interested in applying those theories to specific situations and problems that are relevant for health. So you could think about it in terms of preventing poor health. So health psychologists would be involved in designing interventions to support people who want to quit smoking, for example, or make any sort of lifestyle behaviour change. It can also be about living with illness. So you might have a health psychologist working within a healthcare team where somebody has been diagnosed with a chronic condition. So if the service has the money, then they might have
you expensive?
Oh, so expensive. Listen, you get what you pay for, Connor. But it's often not the priority because obviously, you're very used to triaging and prioritising clinical health problems. The psychological impact of disease is often much more long-term and less obvious. And so often that is not the thing that gets prioritised to spend money on. But it's very important too, obviously, in terms of quality of life, but also in terms of affecting behaviours that then might influence health outcomes. So medication adherence, diet, alcohol use.
Yeah, so disease prevention is where I would first go to when thinking about.
Yeah, so if there is money within a service, they may well pay for a health psychologist to be part of that care team as well. And an example that I had some experience with recently, well, not recently at all, it was blimmin' years ago. But anyway, down in Moulsecoombe, the diabetes team there employed a health psychologist. And I worked with her a little bit, and that was interesting.
So what kind of things did you get involved with that project?
So she was specifically involved in talking, sort of more of a counselling role with patients, and we were looking at possible interventions that might help increase people's well-being. Yeah, but they actually didn't end up having a lot of money to see the project through, so I can't talk about any success of that.
Sorry,
unfortunately.
Okay, we'll move swiftly on,
please.
So, I mean, you've kind of already touched upon this, but also tell me a little bit more about why you think psychology is important in healthcare, and more specifically, can you relate it to pharmacy and our pharmacy students? I can.
The big area that I think often we relate psychology to in terms of pharmacy is medication adherence. And I saw, there's a great quote. I don't know who said it. I'm going to say I said it. The drugs don't work if they're not inside the person, or if the person doesn't take them. So you as the pharmacist or the healthcare team, the clinical team can prescribe and dispense the right medication to the right patient at the right time. But if the person doesn't want to take it, then it's going to serve absolutely no benefit whatsoever. So we know from research that 50% of medications that are prescribed for people with chronic condition aren't taken in the way that they were prescribed.
Sure.
Sometimes they're thrown in the bin, sometimes they're used inappropriately, sometimes they're overtaken, sometimes they're given to the patient's husband to take for something that looks similar. So there's a lot of medicines misuse around. So health psychologists or psychologists within, I mostly work within theoretical, like the theoretical world, the research world, rather than in a clinical environment. So knowledge of the theory of why people do the things they do is helpful to feed into clinical interventions and to feed into educational training to help people who are then working with patients understand why people might do the things they do or why they might not. Human behaviour is complex, and human beings are different but the same, if you know what I mean.
Different but the same.
Different but the same. So I can't remember who I was talking to, but I had a conversation with somebody once about psychology, and that was my interest. And they said, "Oh, that's interesting." It's not interesting to you, clearly, because you're yawning.
I'm so sorry.
I mean, if you're not crying, you're yawning.
I know. I don't know what's going on. Sorry, start that again.
Do you need to take a moment?
No, I'm good. It's just being in your aura.
I don't know what to say.
You were talking to someone.
Yeah, so psychology is an interesting subject. We are all inherently interested in psychology in a way. So I would say that as human beings, we're all psychologists. We're all trying to work out, why did they do that? Why are they acting like that? Why did I do that? Oh, how did that mistake happen? We're all trying to figure out and put some meaning onto human behaviour, whether it's ours or somebody else's.
Sure.
Nobody likes living in chaos. So we have to have explanations for things. Even if that explanation is not the right one, it still helps us psychologically to have some sense of control. I remember talking to somebody once, said that my interest was in psychology. And they said, "Oh yeah, psychology is fascinating because everyone's so different." And I'm like, yes, people are different, but actually psychology wouldn't work as a discipline if everybody was so different, because there would be no theory. There'd be no way of anticipating how somebody was going to behave.
N equals 1.
Yeah, exactly. For however many people there are on the planet. Yes, we are kind of different, and I'm different to you, thankfully.
Yeah, thankfully. That would be very scary if you were a lot more like me.
It would. There'd be a lot of facial hair in our office for a start. But health psychologists and psychologists generally are trying to describe why people think and behave in the ways that they do in fairly generic models. So models of behaviour, so theories about why we do the things that we do. Health psychologists look at, use that kind of approach for how people behave in a health or illness context.
To then hopefully help improve patient outcomes by understanding pathways or decision making or what have you.
Exactly. So it also applies, when you said decision making, it also applies to the psychology of clinicians as well.
Yeah, that's a good point.
So there's a whole, body of research that looks into clinical decision making and what helps people make better decisions in a clinical setting. What kinds of factors might disrupt it. We're not computers. We do make mistakes. We can't possibly process all of the information that is going into our brains and give everything equal weighting. So, for example, in this room, even in this little room, which is a very it's a very controlled environment. So the sound is controlled. There's not much on the walls, yet there's still loads of stuff going on that my brain has to filter out because I'm trying to attend to. I mean, you're finding it hard to attend to me. I can see that.
I know.
But so our brains focus in on some things and have to filter out other things.
And that'll be different for different groups of people, or different experiences might mean that they filter out different things.
Yep. But there are some sort of systematic things that we do. So, for example, when we were talking earlier, you told me about how somebody came into your pharmacy and they had a rash, and your mind went to this condition. I can't remember what you called it.
Johnson syndrome, SJS.
Okay. The Stevens-Johnson syndrome, which you had learnt about in your undergraduate education, and you thought maybe it's that.
Catastrophizing.
I'm not going to say catastrophizing. It's something. So there were a couple of things that it brings up in my mind. So that one thing called medical students condition.
Yes.
Okay. So you learn about something and then you see
Think
it
you've got it. Oh my God.
You think you've
It's
got
like
it.
new car syndrome.
New car syndrome. What's that?
If you buy a car and you see that same car everywhere, I was like, I've never seen this car before.
Yep. And I've had it during lectures. I had, so I give a lecture to the first years, or I used to give a lecture to the first years about, on the lung cancer case, where we would talk about what takes somebody from thinking, I've just got a cough, to then going to a pharmacy, to then going to a GP, and then, that pathway from how do you respond to a symptom? When is a symptom suddenly dangerous? And she came up to me afterwards and said, yeah, I've had a cough for a couple of weeks now and I'm a bit worried that it's lung cancer. And I said, well, you're young. Do you smoke? No, she didn't smoke. I said, it's very, very unlikely for you that it would be lung cancer. But it's that same sort of thing. Once you've got something in your head, it's easy to then diagnose the next thing as that. So you
make it make sense.
You make it make sense. Yeah. Same sort of reasoning as to why people are more afraid of flying in aeroplanes than driving in cars towards the airport. We have this shortcut in our head where we can easily bring to mind catastrophes where planes have gone down.
Yeah.
Even though it's very, very unlikely to happen, but we don't have the same availability of the imagery of a car crashing, which happens way more often. So our decision making can be flawed, and so clearly, clinicians are making important decisions every day, and they're not computers, so there are potential flaws in their decision making as well. So we have to understand how that works and how you can avoid it.
Wow. Okay. Wow. Which will become more and more important in the new MPharm course with decision making and diagnoses and things. So
it's taking more of a role in a pharmacist in the pharmacy career, isn't it? Decision making.
Yeah.
Yeah.
So, next question.
Bring it on, Connor.
So you've been at the university for a little while now.
Yeah, you say that.
I know our listeners would be really interested to know a little bit more about you. So, why did you first go to university to study psychology? And then why pharmacy and why the University of Brighton? Okay, so
psychology. My passion for psychology started off as a sort of, I don't want to say a stand against my dad. I get on very well with my dad. Still love him. He's still around. He's a good man. But when I was choosing my A-levels, I said, I want to do psychology. I'd never done psychology at school because it wasn't offered at school, but I wanted to do it. And he said, Sian, you don't realise psychology will involve remembering a lot of names, a lot of theories, a lot of dates. You're not going to do very well at it, I'm afraid.
Oh, wow.
So I said, right, well, I'm going to show you. I'm going to prove you wrong. So I took it and I did find it quite hard. There was a lot of names and dates and theories to remember, but it was also fascinating. It was really interesting. I actually particularly liked the statistics module.
Okay. You love a statistic.
I love some statistics. And actually, one of the reasons I liked that the most was for that thing that I was saying earlier, that in a lot of psychology, because there's a lot of error involved, there are individual differences that often it isn't easy to know exactly what's going on. I liked with statistics that, well, that's what you do, and that's the answer.
Yeah.
There is no way around it.
Numbers don't lie, yeah.
The numbers don't lie. You can't argue with the data. And so I liked that. So did the psychology A-level, really enjoyed it, then applied to university. Did I at that point? Yeah, I think actually I applied to become a secondary school teacher at that point.
Oh, cute.
Cute. But yeah, I didn't get the A-level grades to go.
Really?
So I had to retake another year of A-levels.
Okay.
And then did get the grades. And in that year of redoing my A-levels, I decided I did not want to become a secondary school teacher for one reason and another. Just, I don't know, went off the idea. But wanted to go into psychology. So did an undergraduate in that, then still wasn't sure what I wanted to do.
Okay.
And actually was really quite down after I finished my degree. You know, university was great. Loved it.
And
Loved
then it was
meeting new
over.
people. Then it was over. And like learning all this new stuff and being able to challenge it. Loved all of that. But it didn't lead to a career. So I'm slightly, I'm not jealous, but I like for our students, the majority of our students, that they have something that they're going to go into. There is a pathway. It's set if they want to go into that. Whereas I think with ours, nobody really knew what they were going to do at the end of it. You come out with a psychology degree, and the benefit is you can go into loads of different things. But the downside is you can go into loads of different things, and you don't know which pathway to take. So I travelled the world instead.
Okay.
Yeah, which was nice. Yep. And spent 10 months just cruising around, which was a lot of fun. And then decided I still don't really know what I want to do. So I'm going to do a PhD. I'm just going to go back to university.
Yeah, why not?
Why not? So I went to Sussex University and did a PhD in something called cognitive psychology. So the way we make decisions, the way we think about the future. Spent 4 years doing that and teaching. And then I thought, oh, this is what I want to do.
Okay.
I actually do just
So you
want to be
did
in a
want to be a
university.
teacher?
Yeah. I want to teach and I want to do psychology more. And I want to stay in Brighton. So then I moved to Canterbury. And oh, actually, that's not true. So then I worked in London for 2 years, doing a statsy kind of job at the Royal College of Paediatrics. And I was looking at their exams and the way they assess doctors. And looking at the reliability and the validity of their assessments. So I did that for 2 years. Then I moved to Canterbury and taught psychology over there.
Okay.
And then finally this job came up here in pharmacy. And I was like, oh, psychology in pharmacy. That's kind of cool. That's different. Applied for it, liked the people, and got the job, thankfully. Graham Davies was on my interview panel.
Was he?
Yes, he was. And I thought, I like you. I'm going to get on with you. And then within 3 months of me starting, he left.
Yeah, but he didn't get on with you then, did he?
He didn't. No, fair. But he's back now, so.
Maybe he missed you so much. He was just like, I just didn't give her a fair trial.
It just took him 16 years to realise that he actually might like me and want to come back and work with me.
Oh, that's fantastic. What a story as well, like, to have gone... You'd have thought that it would be like, that's the straight path, straight into health psychology.
Yeah, not at all. And I'm sure some people do. But I never really knew what I wanted to do. And I think, I have empathy. I've got a 15-year-old son, and... he's at the stage where he's probably getting fed up of people. What are you going to do? He's got no idea. And I completely see that. And
you have to make the decisions so early. And as a teenager, it's like, well, I can't think past next week, let alone what I want to do for the rest of my life.
Exactly. And, we've got students here who have sort of set a career path in a way, but it's not unfeasible to think that they might change their mind as well. And that's fine. That's fine. It is very young to be making decisions.
And I think also, if you think for our students, and we've talked about this a lot, and some of the people we've had on here, a lot of what we do is transferable skills.
Yeah.
So actually, yes, you're a pharmacist. I mean, the world of pharmacy has opened a million doors. You know, your role can be anything you want to get involved in, because actually I think people are understanding our skill set is much broader than they'd previously thought that it was. But also, even if you didn't want to be in healthcare or pharmacy at all, your list of transferable skills and your ability to learn and apply certain things is crucial in many different fields.
Definitely.
So, you know, you don't have to completely know what you want to do. And in 10 years, if you get really bored of pharmacy, you've got a list of transferable skills that can move on to something else. So, and I think for you, you've obviously learnt a lot and moved around and have a whole list of skills that meant that you could have that journey and change.
Exactly. The job that I had in London, which was essentially, it was an office job, and it was number crunching most of the time, but there was a big element of it where I had to present the results of, you know, my statistical analysis to doctors, so to medical doctors who were sitting on the examining boards, and they didn't really, well, this really surprised me, but doctors don't really understand statistics, and that really shocked me. It's like, you know, I was explaining, I don't know, correlations they're okay with, but some of the, like a reliability analysis of an exam or something, which I just thought, you're doctors, you're clever people, you'll know what I'm talking about. And they're like, no, take us back to basics here. It's like, oh, okay. But I learnt loads of skills doing that job that have helped me in becoming, hopefully, a better teacher.
Definitely a better teacher. And then, so thinking a little bit about your time here now then, are there any projects or anything you're getting involved in over the next year or couple of years that might be quite interesting to our listeners?
Well, hopefully, I mean, there's this podcast.
Yes.
This has been great for well, I think it's going to be great for our students, but it's been great for me from a personal perspective, just doing something different. So I'm hoping to get some fourth year project students, as are you.
Yes.
Having a look at developing this podcast a bit more and understanding what students want from it and whether it is an effective tool for, you know, encouraging learning. So that's one aspect. I'm also keen to do more work into paediatric adherence.
Okay.
I have run a couple of projects in the past, PhD students. Our former colleague, Elaine.
Yes, Dr. Sharp.
Dr. Sharp did her PhD in young adults with diabetes and adherence issues. And I'm quite interested to look at younger kids as well. I used to do some work with an old colleague, Angela McAdam, and we used to work on...
That you've worked together, not that she's old. Said an old colleague.
An ex-colleague, I should have said.
There you go, that's
an
better.
Ex-colleague. Oh, damn it. She won't be listening. She'll be listening to Radio 4. It's fine. But yeah,
An old ex-colleague.
And no, she's not old. She's very young. We have the same birthday, which is always pleases me somehow because I like Ange a lot. We had a PhD student together in the past who was looking at parents of children with severe chronic and physical conditions and the problems that they faced in giving their children medicines.
Oh, okay.
So obviously adherence is a big issue. It's more complex often when you're dealing with children because you've also got the parent involved as well, possibly a lack of understanding of why it's needed from the children's perspective. So I've reached out to the hospital, the Royal Alex here, to see if there's some projects that we can do together.
Nice.
So we'll see. I don't know, but yeah.
That'd be great.
Yeah. I mean, we're in a very fortunate position here at the university that we've got nice close links to the hospital, and that we can do some work that could potentially be beneficial for patients ultimately.
Awesome.
Yeah.
Well, we look forward to hearing a little bit more about that as the time goes on.
I'll let you know.
Yeah. So I think this is my last question. I'm going to bring it back to me because...
Well, I knew you would, Connor, because God forbid we talk about someone else for too long.
I know. And, you know, I was just looking at the clock. I'm like, oh, is she going to stop talking? Like, what's going on?
Go on then.
So in my practice as a liver pharmacist, I see a lot of patients who have the start of fatty liver, and I offer lots of things around weight management, reducing alcohol consumption or improving physical fitness. I know this can be difficult for a lot of people, and that journey is quite long for a lot of the patients that I speak to. So why do you think behavioural change is so difficult?
Behaviour change is difficult, you're right, and then we can all see that in our own experiences as well. If we've ever tried to, I don't know, increase our exercise or give up something that we know is not good for us, we might be able to do it for a little bit and then relapse. Often happens. We lose motivation. Sure. So motivation is often a big key to behaviour change. That if we lack the motivation, it's going to be impossible. But even if we have motivation, that can change and it can fade over time. One of the most sort of common models of behaviour that is around at the moment says that there are 3 things that need to be in place for a behaviour to be enacted or for behaviour change to be successful. So one is motivation. You've got to be motivated. You've got to want it. You've got to want to change this behaviour. You've got to want to give up alcohol, for instance. Another one is capability. You've got to be physically able to do it. So if it's stopping drinking, fine, that, you know, you should be physically able to do it. But there'll be a physical addiction there. So that lowers your actual capability to do it. There's also got to be an opportunity to do it. So you've got to sort of, maybe less so with giving up drinking, but if you wanted to take up physical exercise, it's got to be available to you. So you've got to have the time and the resources. You've got to be able, if it's swimming, for instance, that you want to start up, you've got to be able to have the swimming pool nearby you to do it.
You've got to be able to swim.
You've got to be able to, you've got to be able to swim. So if you're motivated, if you've got an opportunity, and if you're capable of doing it, the theory says you should be able to have that, you know, you'll be at in a greater position to be able to change that behaviour. But I think often, and when it comes to healthcare things, it's the motivation thing that changes.
Yeah.
You can think long term about benefits, but often short term wins are more influential. So I can know that long term it's going to benefit me to do yoga every day. So I've got that motivation, but that competes with the more immediate motivation of, but I really like that Netflix show and I'm tired.
Definitely.
So how do we play out those two? How do you suddenly weight long-term goals greater than short-term goals? It's hard.
Yeah.
But you can potentially help people by getting people to think about their own motivations.
Fine.
Okay. So rather than me telling you, well, this would be, you should start walking up the stairs every day, Connor. It's going to be beneficial for you.
It's not going to happen.
It's not going to happen. You don't need to be told that. But if the goal was to get fitter, I can ask you. So
how are you going to do that?
How are you going to do that? But not just how. So that's more like the capability.
Oh, okay, sorry.
But good as well. But also in terms of the motivation, what for you are the benefits of getting more active? So you can reflect on it and you can come up with it. That's more likely to stick with you than me telling you what the benefits are.
Yeah.
So something. I mean, it's in the books, in the textbooks, it's called motivational interviewing. So asking questions, but getting so for the person that you're talking to come up with their own motivations. And I think, it sounds common sense really, but it probably does take a little bit more time to talk to people like that.
Sure.
And it's hard to move away from what's called like a writing reflex, or just trying to tell people what to do. That comes quite naturally to us. Well, you should give up smoking because it will increase your lifespan. Yeah, okay. Well, we all know that, but
again, I suppose what's coming to mind is lots of the times when you're having these conversations, a patient is probably pretty well at that point. If they're not, their motivation might be higher in terms of, they're currently sicker and this is what's causing it. Their motivation might be higher.
Yeah.
But in instances where you're thinking about longer term goals, I like that idea that you've got to reframe it. We know that you need to stop doing X, Y, or Z for your long-term goals of your health.
Yeah.
But right now, the motivation is going to be low because you feel well. You can't see that it's not tangible. You can't see or touch or feel what it is that damages that you're doing or what have you. So you know, like you said, that idea of, I forgot what you called it already. The interviewing, motivational interviewing is reframing and figuring out what it is that motivates somebody else.
Yeah.
And then just reframe your goals.
Yeah. Yeah.
Love that.
Yeah, well, you can have that. Put that in your pocket.
Yeah. I mean, I'm going to need an hour with each patient at this point, I think.
You will, but you might end up saving some time further
Longer
down the
term,
line.
yeah.
If it does encourage behaviour change more than something that may be quicker to, a quicker consultation where you're just telling somebody something.
But I mean, we've talked about this before. Is this idea that that puts the onus on the patient so a lot of the time when we're thinking about disease prevention and reframing what it is that you're doing to make sure you stay healthy, that's putting a lot of the pressure and the onus on the patient to make sure that they're doing those things. Whereas I think we're still in this concept of, but then when you get unwell, there's a magic pill that fixes the problem. When I think actually there isn't a magic pill that fixes the problem.
No.
But I think there almost is that framing of, then when you're unwell, the responsibility becomes the clinicians to solve the problem.
Yeah. Well, yeah, and I think you're almost doomed if we have that perspective, if people are feeling like your health is out of your control.
Yeah.
So once you fall ill, you're now under the control of the healthcare system and the pharmaceutical industry, and that's what's going to fix you.
Yeah.
I think it's not a recipe for success. And
Absolutely
we
not.
know that from research, that people who have, and put some psychology language around it
Do
if you
it.
want. So your locus of control. So where do you put your sense of control over your destiny and your health? An internal locus of control where you attribute good and bad things that happen down to your choices. You will likely have better health outcomes ultimately than somebody who has an external locus of control. So somebody who puts their poor health down to, well, that's my genetics, or that's bad luck, or I don't know why this has happened, or doctors are trying to fix me. They'll likely have poorer health outcomes. So having that sense of control, and you can influence that as the clinical health team. You can give people more of a sense of their own control. Obviously, it's going to differ for different people, and how you do that is going to differ. But if you can encourage and show people that they have control, they will be more likely to be engaged in their treatment and then have better health outcomes.
Are there any specific characteristics about those different types of people in terms of whether their locus is internal or external to them? Is there anything out there that says what types of...
Well, yeah, I mean, there are...
Immediately, I think men are the external and women will be the more internal, but I suppose that's probably overgeneralising.
That is generalising, and I think I don't know what the research shows for that. There are measures of locus of control. So you can certainly put it down to a number, and I'm sure there are studies out there that have compared males versus females.
I suppose, and it will depend on the disease and things as well, I guess, maybe.
Maybe, but even outside of a health perspective, you can look at locus of control. So you have you might have a general predisposition to feeling like you have more impact on your outcomes and environment. So you can think about exam results. If you want, you don't have to, just your educational performance. And that has been looked at, students who have an internal versus an external locus of control.
Okay, that's interesting. So internal being that they can see that what they achieved was
down to the hard
them
work that they put in. And somebody with an external locus of control will say, I did well because it was an easy exam paper.
Ah, interesting.
Yeah.
Okay. So they're saying they did well because of an external reason.
Yeah. Or the markers I had markers who were easy on me.
Yeah.
Or, So those who have a higher internal locus of control and put it down to the work that they did or didn't put in, whatever the outcome, are still more likely to go on and have, better educational experiences, because that feeling of control, it's empowering. Why?
Definitely.
It makes sense, doesn't it? You don't, going right back to what I said at the beginning, as human beings, we don't like to feel out of control.
And then if you think you've got that control over those things, you're obviously going to be...
You can change it, can't you?
Perfect.
Yeah.
So I said that was the last question, but I have one more for you.
I'm not sure I can
And
take
it's not
it.
really a question.
Is it about you again?
It's always about me.
All right, I'll just slip out at this point then.
If you could offer a student pharmacist one piece of advice that they could implement into their practice, either now as a student or in the future as a pharmacist, that could help support patients, what would it be and why?
I think it would just be giving people time to talk. And, I think we've had that come out of lots of pharmacists that we've spoken to, and it sort of plays out in their experience. It's allowing people to tell their story, and it's something that you said that you do in your clinical practice. And I loved it when you said that. It's just, asking somebody at the beginning of any point during their treatment plan and their journey with you, what's your understanding of your condition, what's your understanding of what you're going to get out of this medication, and just being open to what people say, because you just don't know. And it's very easy to expect that everybody's going to give the same responses and have the same understanding as you, but chances are they're coming from somewhere quite different. So being open to that. Can I do a different thing as well?
Yeah, go for it.
So that's
as the co-host of this podcast, you're allowed.
Oh, thank you so much. So that would be for implementing into clinical practice. But I also want to something just for us all as human beings.
As human
beings. I did some research into an intervention that improves mental well-being.
Okay.
It's a very simple intervention.
Is it yoga?
It is not yoga.
Oh, okay.
It's called the 3 Good Things intervention.
Okay.
Okay. So there is an evidence base for it that shows that it increases happiness, decreases feelings of sadness. And it's a very simple thing to do. So even if it doesn't work, it's fine. You can just try it and then drop it.
Forget about it.
Forget about it, baby. So at the end of every day, you just to think about 3 good things that have happened to you during that day, and to think about why it's happened. And that might come back to the locus of control thing a little bit.
Yeah.
And that's all you have to do. Just think of 3 good things and why. So an example might be...
I was going to say, do they have to be big things, or could they be really tiny?
They can be teeny tiny.
Okay.
So, one of mine would be that we shared our wraps earlier.
Do you know what? I was literally thinking of one of my first one would be that we shared and we got to try 2 different things.
Exactly. And why did that happen? Well, because I suggested it and you're a nice guy and you said, yeah, fine. So that would be one of my good things. And so they don't have to be big, no.
Oh.
Because it would be hard to think that there would be 3 massively good things in every day.
I think that's that you're changing the perspective of what a day was. Because, obviously lots of bad things could happen. And I think, just generally we tend to focus on those things tend to hit us harder than thinking about the positives.
Yeah.
And actually, if you, like you said, you're reframing the end of the day to be what are 3 good things.
Yeah.
You're focusing on the good and not necessarily ignoring, but putting to the forefront the good stuff and pushing back the negatives.
Exactly.
I love that.
So it works in that
way. Why
way.
have you never told me this before?
I don't like to give you everything all at once, okay? So we're, give it time.
Do you write them down? Have you got a diary?
I do it in my head. I know people who do write it down.
Because if you wrote them down, how cool would it be to go back to...
You can.
Because then you can almost frame where you are in maybe 6 months ago. Yep. What you write down as being the 3 good things might be completely different to...
It could be, yeah. So go ahead. You just got to do what works for you. And the other good thing...
Stop pointing at me.
Well, I'm going to. The other reason I like it is because, yes, it reframes that day. But what you'll find if you do it for a little while is you then start looking out for things. So you think, that could be one of my good things for tonight. And so
as you're going through the day, you're already thinking of the good things.
Yeah.
Wow. Okay.
So have that, wrap it up in a parcel and open it on Christmas Day.
I will do.
You're welcome.
That's fantastic. And what a great way to end this podcast. So thank you so much, Sian, for taking the time to come down.
Come on down.
Come on down.
You're welcome. Thank you for the questions.
Thank you for having me.
And that brings us to the end of another captivating episode of the Mug Hub podcast. We hope you enjoyed today's discussion and took away valuable insights that will fuel your passion for pharmacy.
Remember to subscribe to our podcast and stay tuned for future episodes where we continue to explore fascinating clinical topics, introduce you to incredible individuals and enhance your skills to bridge the gap from bench to bedside.
If you've any questions, topic suggestions, or you'd like to get involved,
We'd love to hear from you. Connect with us via our social media platforms or send us an email.
Until next time, keep learning, keep exploring, and keep engaging with your studies. Thank you for joining us at the Mug Hub Podcast.